Another study that I had the privilege of presenting at the European Respiratory Society meeting that was held in Amsterdam in September 2015 was looking at patients from the ASCEND study as well as the capacity studies of pirfenidone, in total 1,247 patients, and looking at those patients who had progression of their disease as manifested by need for hospitalization. And the question we try to address is what happens to those patients in the hospital and after hospitalization in terms of the placebo arm and the pirfenidone arm. The number of patients in the first 6 months of all three studies that were hospitalized on pirfenidone and placebo were more or less equivalent. I think there were 47 in the one group and 44 patients in the other group. And what becomes a very important question that we face with in the clinical trenches is, if a patient's hospitalized, what do you do with their medication if they have progression of disease? Because a lot of times hospitalization is related to some kind of respiratory ailment that may or may not be related to the IPF. So should we continue the pirfenidone? Should we continue the drug or not? In any event, these patients were randomized in a double-blind controlled fashion, so we didn't know who was getting placebo and who was getting pirfenidone, but we then analyzed these 47 patients for what happened to them subsequently after their discharge from the hospital. And the primary endpoint of this analysis was either a 10% change in the FVC subsequent to the hospitalization or subsequent mortality. And what we showed is that there was a distinct benefit in the group of patients who continued on pirfenidone versus the placebo arm in terms of this endpoint, which was a composite of FVC and mortality. I forget the exact numbers, I should know these, I was the primary author on it, but it was very different in terms of the outcomes. I think it was like 3 or 4% in the pirfenidone arm versus around 22-25% in the placebo arm. What's very interesting about this data, however, is that most of the patients met this primary endpoint, which was a composite, by virtue of the more significant event of mortality. So a very small number of them met the composite by way of the FVC change of 10%, but the majority, once again, was mortality. And the upshot of this and the conclusion of this particular analysis is that if a patient has progression of disease as manifested by a need for hospitalization, you should continue their therapy through the hospitalization and after the hospitalization. This study was a very nice bookend study to a prior presentation that we had at the American Thoracic Society meeting in May of 2015, where we looked at another measure of disease progression, and this was a 10% change in the FVC. We've all been taught and we all know that a 10% change in the FVC, a decrement in the FVC of 10%, portends a very poor outcome in patients with IPF. We've made the leap of faith that a 10% decline while on therapy constitutes failure of therapy. And we kind of questioned that, whether or not a 10% decline in FVC is indeed a measure of treatment failure. So we looked at patients from all three studies in the two arms, placebo and pirfenidone, and picked out those patients who had a 10% decline in the FVC over the first 6 months. There were around 32 patients in the pirfenidone arm who had a 10% decrement versus 64 in the placebo arm. So even right there, the first 6 months, pirfenidone resulted in a 50% reduction in the number of patients who had a 10% decline or more in their FVC. So we looked at these 32 versus 64 patients for what happened subsequently. Our primary endpoint beyond the 6 months was a further 10% decrease in the FVC or death. Once again, these patients continued in their various blinded arms. Investigators didn't know, patients didn't know if they were getting placebo or pirfenidone. And it was very stark what happened between these two groups. There was a very favorable response or outcome in the pirfenidone arm compared to the placebo arm. The numbers were something like 3% of the patients in the pirfenidone arm met the subsequent endpoint of 10% decline in FVC or mortality versus around 28% in the placebo arm who met that endpoint. What is very interesting, though, is that most of the events that happened were mortality. There were 2 pirfenidone patients who met the primary endpoint. One of them died and one of them had a 10% decline in the FVC. And there were 19 patients in the placebo arm, and as I recall, 14 or 15 of those 19 actually died, and the rest, the 4 or 5 patients remaining, had a 10% decline in FVC. The very important message from this is that even if a patient is declining in their lung function on therapy with pirfenidone, that doesn't necessarily constitute treatment failure, and patients should still be continued on therapy. So this is a kind of a paradox and a paradigm shift. In actual fact, what that 10% decline in the FVC does is it tells you those patients who are indeed most likely to benefit from pirfenidone, so even a stronger case to continue those patients on pirfenidone, because if they go off therapy, it appears that their mortality might be quite high. So hopefully this type of analysis helps us in the trenches in terms of how to manage patients once they go on therapy. The bottom line from this is put the patients on therapy and keep them on therapy no matter what, unless they have intolerable side effects.